Hello and welcome to this week's episode of Dadas Show, coming to you from Pullman Hotel here in Upper Hill, Nairobi. I'm your host, Ashiko Mbune. Now, as always, Dadas Show aspires to promote the spirit of sisterhood and solidarity amongst Kenyan women. And we do this by creating an open and a safe platform for women to discuss issues ascertaining to their health and well-being, their lifestyle and careers, their families, amongst other topics. We also take pride in having the conversations that matter, not only to women, but to families and communities at large. Every day, women in Kenya face life-threatening challenges while bringing life into this world. According to research, Kenya's estimated maternal mortality ratio in the year 2022 was 367 per 100,000 live births. This means that out of 100,000 babies born alive in Kenya, 367 women sadly lost their lives to pregnancy and childbirth-related complications. Now, what we need to realize that these statistics and other related statistics, and behind each of these statistics is a name, a family, and of course, a future that has been lost. On this powerful episode of Dadas Show, we shine light on one of the most under-discussed and very urgent issues, especially in women's health. This is maternal mortality. Why are women still dying from preventable causes during pregnancy and childbirth, and what can be done to stop this? So joining me today are two trailblazers, advocates in this particular space, and together we shall explore what are some of the causes, what are some of the consequences, and of course what are some of the bold interventions that need to be put in place to ensure that no woman loses their life giving life. Of course, remember that maternal health is not just a woman's issue, it is a human right. As always, we welcome you at home to take part and keep this conversation going on all our social media pages at KBC Channel 1. You can also reach us at Dadas Show KBC on Facebook, and myself at Ashiko, the host, across all social media platforms. I am very, very happy to be joined, as mentioned, by the truth sayers, the trailblazers, the advocates in this particular space. These are women who have set apart their time to make sure that women are getting the maternal health that they so necessarily deserve. So right next to me, I've got Dr. Stella Bosire, who has very many accolades. She's one of the people we aspired to be, who is a medical doctor, she's a lawyer, she's a human rights activist, she's a public health expert, and of course, she has very deep insight onto some of the systemic barriers that are stopping women from accessing life-saving care. So karibu sana, Dr. Bosire, and thank you so much for making time to join us. Right next to her, we've got Madam Angela Nguko, who is the founder of White Ribbon Alliance in Kenya. Now, for those who do not know, White Ribbon Alliance has given voices to thousands of women and has pushed for maternal health to the forefront, especially in national policy. So we are so honored to have the executive director sitting here with us to discuss this particular issue of the day. So karibu sana, Madam Angela. Of course, I cannot fail to acknowledge you at home who tunes in every single Tuesday so that you can be able to learn and unlearn and support each other through conversation as we discuss issues affecting Kenyan women. And of course, I cannot fail to acknowledge and celebrate my wonderful audience who take time to sit with us as we discuss issues that are affecting Kenyan women and of course the communities and families at large. Karibuni sana to another episode of Dadas Show. So let's get the ball rolling, you know. I want to start with, actually, both of you can be able to tell me, you know, briefly introduce yourself. I've only touched the tip of what both of you do. I know there's so much more, and this is your opportunity to do that. So briefly introduce yourself and the work, and your work in the space of maternal health and rights. Karibu sana, we'll start off with you, Dr. Bosire.
Thank you, Asiko, for having me. Dr. Bosire is my name once again. I lead the Africa Center for Health Systems and Gender Justice, a Pan-African institution that is committed to addressing health inequities and inequalities from a gendered lens. So women's health, maternal care is at the core of the work that we do. But we take a little bit of a different approach, and our approach is to be able to look at social determinants of health. Those conditions where we live, where we work, that really affect how it is that we access healthcare. And so a lot of my conversation today, even from a maternal mortality, you hear me speak about income inequalities, you hear me speak about decision making, you hear me speak about how power is situated within the homes around who has the resources and how these decisions are made. Because ultimately, it's not just around reaching the facility. It's also about what are the other things that someone has to take into account before a woman is able to access Dr. Bosire for her delivery.
Oh, wow.
Thank
you so much. I'm really looking forward to that, and you know, to picking your brain on certain topics, especially around maternal mortality. So thank you so much for that. Let me move on to you, Madam Angela. You know, please tell us a little bit about yourself and the work that you do in this particular space.
Thank you, Ashiko. My name is Angela Nguku. I founded and lead White Ribbon Alliance for Safe Motherhood Kenya. One thing that many people don't know is that I'm a midwife.
Yes.
So I was a midwife before I became an advocate.
Yes.
And I think my story is long, but for almost 20 years now, I have really, let me say 10 years, I was really like working in different spaces, in development, in practice, in training, hoping that I would see less and less mothers dying. But the more I hoped and waited, the more I lost it, because so many continue to die.
Yes.
And the number that you just told us is basically just a snippet. It's the average.
Yeah.
And I say this because what I bring to the table, what I bring in the work that I do, is actually surfacing the voices that are the truths, the hard truths from the women and girls themselves. So the work that I do is really to bring the voices to the fore. So far, 3.5 million women and girls across the country, mostly underserved, mostly from the places that no one talks about, really speaking about what is really ailing, what is really killing us. Not any study, no nothing, just the lived raw truths. And for me, I say truth is my strategy, listening is my leadership.
Wow.
And so far, my work is really centered around the women themselves, the girls themselves, not filtered, nothing. And that is really, for me, what is really powerful and what is important. So for me, my strong belief is that the solutions that we create for women must start with the women themselves. It is the wearer of the shoe who knows where it pinches most. So you can't craft solutions from air-conditioned boardrooms and assume that they are going to save mothers. And that's what I bring to the table.
Wonderful.
Yeah.
Oh, thank you so much. We are truly, truly honored to have you here. Let me move on to you. You know, you did mention something, Dr. Bosire, about before the mother comes to see Dr. Bosire, there are certain things that have already come to play. What are some of the leading causes of maternal deaths in Kenya?
Now, let me first give an overarching principle around perinatal and natal and postnatal care.
Yes.
Basically looking at a woman during pregnancy, during delivery, and after delivery.
Yes.
As there are certain conditions which are influenced by certain factors. So for example, let's see perinatally. WHO recommends that women need to attend clinic 8 times before they deliver, you know, between the first and the last trimester.
Yes.
There are very important reasons why this is a recommendation. Number one, we are able very early to put these women on prophylaxis. So you hear us do vaccinations, you hear us screen them for certain diseases. If you find they are infected with certain diseases that are easy to be transmitted to the fetus, we are able to take care of that. We are able to pick complications like high blood pressure. We're able to actually now start thinking about her delivery process, because it's then that we understand, is it a prima gravida, which is a first-time mother? Is it a mother who has had babies? Has she had any complications? So we preempt, is this going to be an SVD, which is a normal delivery, or is it going to be a cesarean section? It gives us that time. Yes. Unfortunately, for those 8 number of times, there are multiple factors that have to be taken into consideration. Number one, let me take what we call red flag patients, who are patients who require specialized care. It means immediately she misses her period, she has to access facilities. And a lot of the times it's not level 1, level 2, it actually starts from level 3 going upwards, meaning it's not a facility within her, a residential area. Yes. She has to get money to go to hospital, right? Transport money. A lot of the women that we serve Angie serves, and me and I serve, are women who come from low-income households. These are women who make less than 300 shillings per day. Akifikiria, if she thinks about that transport, she says, let this pregnancy keep growing, I will actually make that decision.
Exactly.
So there's a delay from that decision around, and it's an income delay. Then there's a delay around transport, because we have not been able to invest heavily within improving accessibility. And so what happens is that she'll be like, no, I would rather not go.
Yes.
Let me wait longer. What does she miss? She misses an opportunity for us to look at her hemoglobin level in the early, in the first trimester. She misses the opportunity for us to do the first ultrasound. She misses an opportunity for us to screen for the diseases. What does that lead to? And so when I divided the pregnancy into 3 stages, the perinatal, antenatal, and postnatal is a reason. It's because when you talk about obstetric complications, we put it within that period up to 6 weeks post-delivery. And so this first stage, one of the reasons, one of the key causes of maternal mortality is obstetric hemorrhage, bleeding. And so women bleed for many reasons, right? Number one, which is the most common and which is now a service issue, and that's why they need to be able to be followed very quickly, very early, is if there's a complication in a placenta. Sometimes the placenta is situated in an abnormally anatomical area. Sometimes the placenta separates, and if they are not able to reach the hospital, 2 things can happen. She will lose the fetus and even her own life. She can lose her own life. You see, again, we started from the issue of decision making, money to actually see a Dr. Bosira or a specialist around that. Then that's one. Anemia is a very common cause in pregnancy. And the first thing that we do, we put women on iron supplements. We also put them on vitamin B12 supplements, because the 2 of them are very important to prevent neurotubal defects, which you had spinal cord complications for the growing fetus. And that's why immediately you miss your periods, we start you on. Iron also, you're growing. There's a little human being growing in you.
Inside
they
you,
take a lot from you. And one of the things they take from you is iron. And so there's anemia in pregnancy a lot. And so what we do, we also put you on iron supplements. Every single nutrient that the fetus is relying on is coming from you. It's the things that you eat, it's the things that you consume. And so it gives us an opportunity to actually start doing that early care. And now you miss that opportunity, you come to us. A lot of the women who come to us within the first pregnancy, a complication, they come to us with what would be termed as a threatening abortion, which is a miscarriage, right? And they come bleeding and they're panicking. And we do our clinical diagnosis, we do our laboratory. We actually find that, oh my God, we missed an opportunity.
We missed an opportunity to detect this.
If, for instance, you have what we call cervical incompetence, meaning your cervix is not so weak to hold a pregnancy, there's a technique that our specialists put called the McDonald's stitch to hold it in, so that even as the fetus is growing, that weight cannot be able to expand. And so lots of them, actually 20% of pregnancies end in spontaneous miscarriages. Nobody knows. Like you would miss your periods, and then the next time you have you see, oh, I'm having my periods. It's actually not. So you actually have spontaneously missed your periods. And so that's the first thing. Then the second thing is during delivery. During delivery. You come to delivery, you've stayed at home for a long period of time. We usually tell women, please do not let the sun set and rise and set when you're still in labor pain. We have qualified nurses, even though overstretched, who have tools like Patograph. They're able to chart since you came in. How are you progressing? They look at your cervix, they say, this is progressing well. No, Daktari, this is not progressing well. Maybe they find, this pelvis is too small, and so we need to be able to start preempting and planning for a cesarean section. And they have expertise to be able to say that. Now, because you delay at home, by the time you come to our facility, there's another delay that happens. Now, one nurse takes care of 30 patients, and this is a public facility. What happens? Mikono ashike hapa, ashike kule, and so days are constrained there. The other issue around our facilities also, this is another delay, is that we do not have enough commodities.
Yes.
Right? Is that there are certain commodities that require including equipments, like the mobile ultrasound. I can tell us how the fetus is, is it still moving, the heart rate, we can hear. They don't have that. They don't have important drugs. They don't have fluids, you know. And so what happens? There is another delay in this woman accessing care at that facility level. And so even when she delivers, and remember she's come home in 3rd stage, mtoto anatoka, the baby
anatoka is already on the way out.
Is already on the way out. Then the nurse calls me and says, Dr. Bosire, we have a problem. We have meconium. The amniotic fluid after the rupture of membrane is supposed to be very clear.
Yes.
But then we start saying it's colored. It's green, blackish. That means that the baby is tired to a point that they are able to actually poop in the woman's
womb,
in the womb.
Yeah.
And so what you people see, as we see this is then we start staging. Is it stage 1, stage 2, or what? Because now we start saying prepare theater. Anytime we lose, we are going to either lose that fetus or newborn,
or the mother,
or we are going to have complications. One of the complications that results in, which is common, is cerebral palsy. Because now there is no oxygen that is flowing to the brain of the baby and all that, and that complication can worsen. But also contracted long labor contraction is not good for the mother, because it weakens the ability of the uterus to contract back once the products of conception have been expelled. And so if you're not in a facility where there is blood, put a pin on blood, because that's our greatest. If there's a call I need to make today to Kenyans, and Kenyans are watching this, Asiko, is a kindly donate blood. Blood is a product, it's medicine, it's life-saving. So you go to this facility, we have tried. The baby has come out. The uterus refuses to contract back.
Oh,
we are running around, we are saying, do we have oxytocin? What are we doing? We need to start blood because it's gushing. And then if you're not in a facility with a trained midwife like Angie, with a qualified doctor who would actually now completely take you to theater and try to be able to reduce that bleeding, or you can be given blood products. That is why we are counting 17 women dying every single day in this country.
Oh, wow.
Because on average, because of maternal related complication. And then there is post-pregnancy.
And now here we are post-pregnancy.
Now we start thinking like sepsis infection, right? Because for one reason or the other one, maybe a product of conception was left in, maybe it's a hygiene, or one reason or the other one, we call it sepsis. And that infection, sometimes it's very silent. So you come to us, you've just been, we usually, the lock here, after you've delivered, we start telling you, please, look at that pad and chat for us. How many pads are you changing in a day?
Yes.
What is the color? Is there a smell? Those are very important things to me as a clinician, because I quickly pick a red flag, right? And I quickly intervene. A lot of the times, again, remember those delays from this woman, zile zilikuwa za mbele za pesa, za decision,
access to the facility still there.
They're still there. Then they come to this facility level 2, which is next to them, they can get medicine. Angie, we will never, Angie, stop counting these 17 women on average who die per day. And I've just spoken about one, obstetric hemorrhage. I've not spoken about hypertension in pregnancy, what we usually call preeclampsia, preeclampsia, which is actually another life-threatening. People need to understand that it's not just the hypertension alone, it's the complications of the hypertension. Women go into liver failure, kidney failure. Women have gone into ICU because of preeclampsia. Then there's, of course, issues of unsafe abortion, which is another thing that we discuss. We talk about it openly because of accessing unqualified practitioner, unqualified facility, and that is actually contributes also to maternal obstetric hemorrhage. And the other thing, which I've touched a little bit about it, is on sepsis. All these factors are not just dependent on an availability of a hospital. They are dependent on the knowledge of this woman. Does she have information? These things that Dr. Bosire is saying, have they been able to reach them on the ground? Does she have resources to be able to make quick decision and say, I need to quickly at least do 8 antenatal visits to my facility. Are there people within her that are supportive? Does she have resource to access nutrition? Because remember, the growing fetus is taken from her. All these factors have to be taken. I know it's a mouthful, but you need to remember that those decisions are not just dependent on me, as Dr. Bosire, the facilities. There are social issues around these women that need to be addressed.
Wow.
Thank you.
Thank you so much. And you're definitely right. I know that over to you, Madam Angela, you've talked about dealing with women from the low economic, sector. Based on your research, who are the most that are affected by maternal mortality in Kenya?
Thank you, and thank you, Dr. Bosire, for that. For me, I would say the women that are at the lowest in their earnings, the poor, the underserved, the adolescent mothers, the women living disability, the migrants and refugees, the rural poor, the urban poor, the nomadic, the indigenous, and any other woman who is really like at the lowest scale when it comes to their earning power and the like. And I think the same woman, because poverty poverty wears many hats.
Yes.
Anyone who has poverty, there's illiteracy in that place. There's low socioeconomic status. There are many maybe cultural norms that are ingrained there, because without education, then there's no empowerment. At the end of the day, there's so much of that. And so I would say that it's that woman who is really at the lowest in the banner, the underserved woman, I call them that. And the other thing that really complicates is the whole gendered issue.
Yes.
The fact that they are women. So gender plays in, because when you are a woman, where is your decision-making power, as Dr. Bosire has talked about? And I'm saying this not just based on my truth or even data that I'm read somewhere. It's based on what we've heard from women and what we've seen. At White Ribbon Alliance Kenya, we work with women across all these spaces, across the 47 counties. We've listened, as I said earlier, 3.5 million women and girls across board. Is not a small number. And we've not just listened once. We are on our 9th listening. And so far, the recent being what we listened around over 97,000 voices telling us what health, well-being, and self-care means to them.
Yes.
And for us, what they said and what was so central, and when I say this is so powerful, is that it's money. That was central. Access to money. And I'll tie back to a documentary we did, because we use storytelling as a solution.
Yes.
Because until people say their stories, until the hunter, the lion learns how to tell the story, the hunter will always glorify. So instead of reading these DHSs and the like, reading a lot of studies that I hear being done by a lot of actors, I think it's important also to let the user of care, who I call the real expert, it's actually the person using the care who should be able to tell you what does the care look like, that experience and the like. And so for us at White Ribbon, that's our strategy, starting with the listeners, the users themselves, who have been left out for the longest time. And so when we did this documentary last year, it was basically stories of mothers lost, fathers left behind, and newborns lost. Those who have lost what was actually the story. And what came out is that they never had bus fare to get the facility. They never had, there was no fuel in the ambulance, and they were being told to fuel the ambulance. When they go to that facility, they were not told what was ailing that mother. I remember a mother from Kajiado, deep in Kajiado, very far, almost near Tanzania, who said, I have lost 5 of my 8 babies because nobody really told me what my problem is. And it was very simple. It was a loose cervix, what Dr. Stella was talking about. Until she actually got an Arambe from the community to take her through a 25-kilometer journey on a motorbike, bleeding, and she still lost that baby. She could not afford a motorbike. She had to get an Arambe. She's poor. She's nomadic. She's illiterate. She's living very far. And for me, that is really powerful, because it's a lot of, I actually call it now a polycrisis. The whole issue around maternal health and health in itself is a polycrisis. It's a crisis of income. It's a crisis of information, education. It's a crisis of dignity, respect. We forget that we tell mothers to go to the facility, but what kind of treatment are they getting at the facility? Because dignity is actually the #1 request for women and girls when we ask them, what does quality care mean to you? It's dignity. I'd rather choose between going to be shamed in front of other people, or going to be reminded, oh, I'm poor, or going to be told when I have to go and buy other things, because I'll get to the facility There are no commodities that Dr. Steras talked about. And then at the end of the day, I have no money. And then if I don't buy, I'm shouted at like, so why did you come?
Exactly.
So there are many things that a woman has to think, where am I going to leave my children with? It's a unpaid care work that women do at home. I have other children. Who is taking care of them? I'm the only breadwinner. I have to go and sell my goats or tend my goats or do so many other things. Who is going to do that when I'm gone? So a woman has to think beyond so many things before I can even decide to go to that facility. And the other thing is water access. These women do not have water. They're the ones who fetch water. They're the ones who look for take care of the household. So I have to think between going to fetch water and going to the clinic or going for immunization or going for anything else. And at the end of the day, I'll decide I'm not sick. The pregnancy is still progressing well. You don't know because you've not been assessed and the like.
Exactly,
so
yeah.
I call it a polycrisis. It's many crises that are colliding. And at the end of the day, who is suffering? It's a woman. So we are losing. I say 17, but I say that with that pinch of salt because that is on average. What is captured on data that is collected after such a long time. Truth be told, every day we are in these counties, we are losing much more. Some of them are not counted, they're just buried. And a man is told you'll marry another one
and you'll get more children.
I've not even come to the number of newborns. On average, we lose 92 newborns every day in this country, on average. But remember, this is average across the 47 counties. There is masking of iniquities and inequalities that exist, and they play out in these counties and the like. So I think when we talk about maternal deaths, I call it everyone's business. And it's not a health issue. Now, that's another thing.
Of course, yeah.
I feel like a lot of times, we look at maternal health, maternal mortality, maternal deaths from a very developmental issue.
Yes.
I'll tell you it's a justice and rights issue. It has nothing to do with development. It's all about the decisions that we make to decide women's lives. Mothers' lives are worth saving. As someone said in 1988, long time ago. It's until they start, I think, mindset that women's lives are worth saving, that these rights must be upheld. And at the end of the day, we must safeguard, but we must start by listening to these women. Then we'll be able to get anywhere. But as long as we keep on thinking it must be done this way, but most importantly, we are keeping on giving it to someone else. It's another country. You go and fund it.
It's the hospital. And you know what?
Exactly.
Sorry to cut you short. What I've actually just realized, even when we came into this conversation, I think myself and like majority of the people who are watching us, we thought it was a health department problem, hospitals. And the more you're talking about it and you're breaking it down from a very, very basic level, from the lady at home, it is starting to look like, of course, yes, it's actually a justice and injustice situation. And a social norm.
I had a patient when I was working in Moranga,
yes,
who came to deliver, and she needed an emergency cesarean section. She refused to sign consent until her husband came.
Oh dear.
And then we ended up with what you call an IUFD,
yes, an
intrauterine fetal demise, because of that delay. We had seen using the fetoscope, the heart rate was going down, but because decision making is hierarchical in the household. The man came when he had finished his work at the end of the day, and we lost.
And the baby had already
died. Right? And it was such an unnecessary. Any maternal or neonatal demise is an unnecessary.
Absolutely.
Where we are. At that point, I was on call, I was present, the nurses at the labor ward were present, the theater was not
Everything
busy,
was ready to go.
Which is not usually the optimum.
Yes, absolutely.
Everything was optimum. Yeah. But there was a norm issue around who decides when a woman goes to theater. And it's not just around, and this is what we talked about, power. Sometimes it's actually the community.
It's a community.
You know, it's a community. In certain regions within this country, is that women do not deliver in hospitals. You're told, even your grandmother and your great-grandmother,
everybody delivered at home.
What is special about you?
What is so special about you? Why do you need to?
Exactly.
Let me follow up with that one and ask you a question before we actually go on break. Okay, so we are looking at maternal mortality on a broader spectrum. Because, and I'm so happy that I feel like my eyes are open and I'm thinking, okay, so it is not linear, you know, it's far reaching. What are some of the policies or interventions that currently exist to reduce maternal mortality. So it's already been established that it is a community problem. It's an government, everybody is involved. But already existing, what are some of the interventions that have been put in place?
I mean, if you think about the building blocks of healthcare, usually I look at systemic approaches from the building block. In terms of health governance, we really have had proper policies. We have a whole entire constitution around fundamental rights and freedoms. Literally Article 43 speaks to the highest standard of health, including reproductive health. We have our Health Act of 2017. We have our Children's Act. We have Article 53 that speaks about children's rights. We have Article 26 that speaks about the right to life. We literally have statutes and constitutional provisions that are supposed to safeguard. But there's something that's happening here. It calls for progressive realization of rights, right? And progressive is knowing we are developing a middle lower income country, and so we are not going to be able to get there like this.
Yes.
It takes steps.
Yes.
Where we are right now, Kenya was one of the countries that committed itself to ensure that at least 15% of their national budget goes into healthcare.
Yes.
One of the greatest areas of need in healthcare is within maternal and child health.
Yes.
As we speak this financial year, there was only an allocation of 3.3% of the total budget to healthcare. If you hear the number, it's 133 billion, you get excited.
You keep on thinking that's a lot of money, yes.
Until we break it down to you. It is unfortunate that multiple facilities right now really are on a starvation. And then in terms of service delivery, really we overstretched our providers. We've overstretched our nurses, we've stretched our doctors, we've stretched our lab people. We need to be able to act. And I like the reforms that are ongoing right now around human resource for health that is integrating the community health practitioners, because those ones become our ears and our eyes.
Yes, and they're on the ground.
And on the
exactly.
ground. So wanaona Stella kona mimba, the first thing quickly, umeenda clinic. No.
Umeenda clinic, umeangaliwa.
You know, they take all that data because there's an algorithm that has been developed by the ministry, and they quickly refer so that if it's a normal, non-eventful pregnancy, we would work with her. But if it's one that requires immediate urgent intervention, we really act very quickly.
Okay.
And so that's on commodity security. The other thing, and I think which does not necessarily fall within any of the 6 building blocks of health system strengthening, is around political will. I say this and I say it broadly. This political class, this political administration must love the women and girls in this country, must be committed to improving their healthcare. We are 50% of the population in this country. If you do not invest in our healthcare, you're literally disadvantaging the whole entire nation. It has been proven that for every single dollar that has been invested in women's health, the return for investment is $3.
Of course.
Why are we losing this money?
Why are we losing that money? Let's take a small break. I mean, this is, like I mentioned, it's definitely a powerful and engaging conversation, which we will carry on right after this break. Don't go far away. Welcome back to Dadas Show, where women's voices, they rise, they lead, and they build the future. This is definitely my favorite part of the show, which is a question and answer session, which gives an opportunity to my wonderful audience to ask questions in relation to today's conversation. Remember, if you have a question, if you have a query, if you've got feedback, please do not hesitate to reach out to us on our social media pages at KBC Channel 1. You can also reach me at Ashiko the host, or Dadas Show KBC on Facebook. Remember, all aired episodes of Dadas Show can definitely be found on YouTube. So let's jump straight into the question and answer session. And our first question of the day is from Edith. Karibu sana.
Thank you so much, Ashiku. So what I'm getting from the conversation is that maternal mortality is contributed by so many factors, but it's purely pinned on the health system, the nurses, the midwives, the doctors. But what I'm getting is there's so many contributors to maternal mortality. So why do we put the blame on the midwife and nurses? And is this fair to put the blame entirely on the health system?
Yeah, thank you so much for that question. And I think this is something that we hear a lot in the work that we do, but I can also attest to it as a formerly practicing midwife and turned advocate and the like. I think people blame what they see. So the mother leaves the home, she gets to the health facility. Nobody really speaks to that mother, but also speaks to that midwife or even doctor to really say what is really happening. So whatever is blamed is what you find there. It's almost like, I like giving the analogy of the matatu in our country, where you go, the conductor talks to you badly, but you don't know whether that conductor has been quarreled or whether there's enough fuel in the matatu or anything like that. Out of the work that we do at White Ribbon Alliance, we've listened also to frontline healthcare workers. We listened to doctors, we listened to midwives, we listened to nurses. And one of the surveys that we listened, that was like 3 years ago, what we heard from these frontline healthcare workers really was heartbreaking for me. It took me back many years because I thought after leaving the practice, maybe things have changed.
Yes.
Mothers had told us that they are being disrespected. So we needed to find out from the midwives, the doctors, and the nurses, why is there disrespect among the nurses? But it was so heartbreaking to listen to these very frontline healthcare workers telling us, the system has failed us. Every time we speak, we are told, you go and work. We don't have gloves. We don't have blood. We are mentally really constrained because we witness a mother dying. There's nothing you can really do because there's no syringe. You are like 10 mothers delivering at the same time, and there's only 2 nurses on duty or 2 midwives on duty. Relatives have come. They want to see their patients who is really in a dire condition, as Dr. Stella talked about, being attended to. But I'm only 2, or I'm only 1. I'm supposed to be giving either the mother who is in labor, the mother who is in postnatal ward, who is after being delivered, and I'm supposed to be taking care of the newborn who might be having a complication. I might not be having blood. Maybe I'm running to look for the ambulance to refer that mother to another place. I mean, it's a whole course on. It's actually disrespect also to the frontline healthcare workers. But everybody else is there. Them on the front line. They are the ones you'll find in the clinic. And that's why at White Ribbon, we started a program called Care for the Carers, Self-Care for the Carers. We actually have a program and even coaching for the front lines, where we talk to the frontline healthcare workers. We give care back to them. We elevate their voices also in different spaces. We bring them to spaces to speak to the duty bearers, to politicians, to speak to funders and other actors to actually realize that we need to invest in them. They're also suffering at the end of the day. So I think my call to all people out there is to support these healthcare workers also.
So if a complication happens, I think we also we owe it to the people to actually investigate where did the problem come from. Because if the lady has not been coming for prenatal care and she's come with a complication a little bit too late, then who can we genuinely allocate the blame to?
I think I say a lot of times, and I'm saying this as a health worker who has, as I said earlier, I've held a torch. I'm praying at the same time so that I don't lose this mother. I'm praying that an ambulance comes so that that mother can be transferred because I don't have blood where I'm supposed to be delivering that mother. I keep on saying, can we afford more grace to these healthcare workers on the front lines who are really battling so much? I can't tell you how many times I cried at night because where I was working, the theater was not working. There was only one doctor on call, and they're supposed to be taking care of so many other patients, and I have nothing. And I want to save this life. At the same time, I'm really praying for this relative, this patient, who I don't even know. I just want to save her life because I was trained to save her life. But then I've cried also because I've lost that life. And that is the story of so many frontline healthcare workers. And that's why I chose to do this route, to just speak, advocate, because we need to speak up for them too.
Okay,
In 2 minutes.
Yes, briefly,
I was pregnant when I was working in Moranga, and I was on call, and I had severe preeclampsia, high blood pressure in pregnancy, and that night when I was on call, my blood pressure shot up to dangerous levels. I was in theater saving women and their babies, their newborns. The next patient on that table was me. We had to wake up my colleagues to my personal story. I've written about it, spoken about it. Not somebody else, me. With high blood pressures of 170, 210 systolic, 170 diastolic. And literally, anything, I went into the ward, I took the admission book, I'm speaking to the nurse and I'm admitting myself. The nurse says, Daktari, where is the patient? I say, I'm the patient. She puts the blood pressure cuff on me, finds it so crazy, she starts calling the rest of the colleagues. I was so swollen, and preeclampsia, because of you lose a lot of proteins in the kidneys, I became as dark as distress. So even finding a line was so problematic. I had a colleague on my leg, I had another colleague on my arms, all of them trying to find a line. As our senior consultant is driving, literally crazy speeds to come and operate and save my son. My son was born premature. At 32 weeks, stayed in the nursery of Muranga Hospital, was taken care of in Muranga Hospital. Wow. And so it's not what Angie is saying, it's actually a reality. And I sit here as one of the patients probably who would have been managed by Angie. And yet, I was in a facility. I was on call that night. Wow. And so these realities are realities of all these women, some of them who are not fortunate enough, like Stella, to have health information, fortunate enough to have colleagues, to be living in the hospital, just across the hospital where the doctors put us, to actually know, my goodness, when I started feeling epigastric pain here and vomit, I walked myself quickly and I told the nurses, BP machine, start magnesium sulfate.
That is definitely because of the information that you had.
Information.
Oh, wow. That is really, really, well, thank you so much for sharing that with us. Our next question is from Victor. Victor, karibu.
Okay, we've talked about the cases, some of the cases and the causes, and I've not heard you mention of some of the measures that have been taken, if any. Maybe will you kindly identify some?
From a service delivery point of view, because clinicians like Angie and myself have only control in as far as when you come and present in front of us. I think one of the biggest investments have been like work around advocacy to center patient-centered care, understanding rights, has been something that has been invested in, so that obstetric violence that we've been experiencing, like you hear a woman has gone to deliver and she's being beaten, she's being indignified within facility. There is a lot of work that has gone into there. The other work within service delivery is around commodity security. Unfortunately, we are not where we need to be. We have a lot of stockouts in this country and we need to be able to address this. The other place where there's some effort that has been done is in terms of standardization, what we call standard operating procedures. That if a woman comes to the facility and she presents like this, what is the next step? That standardization really ensures that every single person who works in that facility is able to access the highest quality of care, right? And the other thing that I think, which is also an emerging issue for the last couple of years, is that we've integrated the voice of patients into even service delivery decision making, and that has become very powerful. Some of the changes that have been seen, for example, in the Kenya Medical Practitioners and Dentists Union, Dentist Council, has been the removal of making it a technocratic space to actually even invite representatives of the public or the patients into that space of regulation. So those are good innings. The Health Act of 2017 is a good movement around it, right? And right now we have 3 other statutes. They're very problematic in terms of social health authority, but are they promising? I see some light even as much as I see more darkness right now. And if only we would put in money, if only we would invest strengthening our supply chain, would ensure that our governance is airtight, then in this country we will not be able to speak about maternal mortality very quickly in the near future.
Wow, thank you so much for that. And we definitely pray for the best. We definitely pray for the best. And we, of course, urge you on with a message from Dadas Show that we really, really do. We are in support, and we are really hoping to the day that the ratio is going to be, no deaths. Yeah, no deaths. So thank you so much for that. And we've definitely come to the end of this episode. Please give us a parting shot in regards to today's conversation. Yeah, I'll start off with you and then we'll finish off with Madam Goko.
Asiko, it is everyone's business to invest in maternal care because the return for investments benefits everyone. And so we must be intentional in investing in maternal health if we are to reap the both economic and social outcomes out of it.
Yes.
Thank you.
Thank you so much for that. Madam Goko.
I think just to echo what Dr. Bosiri has said, at the end of the day, we can't keep on saying that we are leading people as leaders in this country if mothers are still dying. So there needs to be a deliberate turnaround to really ask ourselves what is killing mothers. And I think the leadership of this country needs to wake up and really focus on what is killing women. And they can only do that by listening. Asking and listening what is really killing. Instead of building many more infrastructure to be seen cutting ribbons and the like, I think it's important to ask themselves, why are the ones that are there not working?
Exactly.
Why are mothers still dying?
Yeah.
But at the same time, communities also have a right to demand for what is better. I keep asking myself, during political campaigns and the like, there's so much education around that. Why is there not so much education around maternal health issues? Literacy to make women understand what do I need to do and where do I need to do.
Thank you so much. Really, really well said. And I really want to extend gratitude to my wonderful panelists. I mean, it's definitely been one of the most powerful and engaging sessions that we've had, talking about something that is so urgent and yet under-discussed, maternal mortality. So thank you so much, Dr. Basiru. Thank you so much, Madam Goko. Thank you so much to our audience and for even you at home for tuning into Dadas show. We've definitely come to the end of this week's episode, and we want to extend a very great hand of thanks to our location partner, Pullman Hotel, here in Upper Hill, Nairobi, the production team at KBC, myself, Ashiko Mbune, and we wish you all a compassionate, graceful week. Remember to get in touch with us on all our social media pages at KBC Channel 1 and on Facebook at Dadas Show KBC. But until then, let's see each other next week, same time, same place. But for now, goodbye.